everybody. I am Agostino Consoli. I am Professor of Endocrinology at the University of Chieti in Italy, where I also chair the Diabetes Clinic and the Institute for Translational Medicine. What I would like to do in the next 7-10 minutes is to discuss some feature of GLP1 and GLP1 receptor agonists related to their action on the cardiovascular system. You know very well that GLP1 has a lot of action that they may be useful for the cardiovascular system. This may be indirect in that this hormone regulates glucose and lipid metabolism and also acts on the vessel to promote NO production, and also directly on the heart because there are receptors on the myocytes, and in these cells GLP1 exerts anti-apoptotic properties. So all the preclinical data may lead us to believe that GLP1 and its analog may be protective toward the cardiovascular system. However, although all the preclinical data would let us think that these molecules have a beneficial effect on the cardiovascular system, no such proof existed until a few years ago. And also, when these drugs were launched on the market, together with all the new agents for treatment of type 2 diabetes, the FDA issued guidelines for the industry where they called for the need to demonstrate in an absolutely incontrovertible way that these drugs were not harmful for the heart. So that once you look at the phase 3 data, you need to have an hazard ratio versus placebo less than 1 and the upper bound of the confidence interval not exceeding 1.3. Now, given the way in which phase 3 studies are conducted, and given the small number of cardiovascular events that you accrue in this phase, it is almost impossible to have such a narrow interval, confidence interval, to be below 1.3 with the upper bound. So that virtually all of the new drugs for treatment of diabetes had to go a randomized controlled trial, a safety cardiovascular outcome trial, to definitely prove that they were not harmful for the heart. And this has consisted in an enormous effort, which is still going on, with over 130,000 patients enrolled in the studies, and as you know, as you can imagine, a lot of effort in patient time, physician time, and money going into these studies. Now, what are the characteristics of this study? In order for them to be feasible, you need to have sufficient number of events in a relatively short time and with a bearable number of patients. That's why in all of this study, patients were enrolled were at very, very high risk of cardiovascular events. In most of them, 80% or more of the patients had established cardiovascular disease already when they were enrolled in the study. The study were placebo-controlled, and they usually were performed by adding the drug of interest to whatever treatment was used at that moment for diabetes. And the other diabetes therapy could be changed according to the investigators, according to current practice standards, so to achieve the best possible metabolic control in the attempt to achieve equipoise, meaning similar metabolic control between one arm and the other, placebo versus active drug, although this equipoise was seldom, if ever, achieved. We will concentrate it on the 4 studies which have been published so far, where GLP1 receptor agonists were used. The one with exenatide, lixisenatide, semaglutide, and liraglutide. What were the results of this trial? Basically, in the lixisenatide trial, there was convincingly shown non-inferiority versus placebo, so no signal of harm, but absolute neutrality versus cardiovascular events. The hazard ratio was 1.02. In the Excel trial, lixisenatide, which is the last to be published, actually the score was a little bit better, 0.91 is a hazard ratio, but still no significance in terms of protection of the cardiovascular system. Whereas in the study with the liraglutide, the leader trial, a significant 13% reduction in MACE was observed, and in the SUSTAIN 6 trial, an amazing more than 25% reduction in cardiovascular event was observed. Cardiovascular mortality in the leader trial was also analyzed as a secondary endpoint, and was the only trial with GLP1 receptor agonists where cardiovascular mortality was significantly decreased by 25%. Now, the conclusion of this is that all GLP1 receptor agonists are safe in that they do not imply risk for the cardiovascular system. We kind of knew that, but now it has been shown with randomized control trial. But also, in addition to this, the occurrence of MACE in subjects exposed to GLP1 receptor agonists was in some trials, specifically in the trials performed with liraglutide and semaglutide, lower than in the subject exposed to placebo. So a question arises. One is this a class effect or is specific of some molecules? And the second question is how much of the observed benefit was due to a direct effect of the molecules on the cardiovascular system, and how much was due to the amelioration of metabolic control, which was seen in the active arm. Well, if you take a look again at the result of the study, you would see that the ELIXA trial actually had a hazard ratio which was consistent with what was observed with the DPP-4 inhibitors, meaning no benefit whatsoever, where the other trial actually were all on the left of the identity board. And this may be explained by the fact that the pharmacodynamics, the pharmacokinetics of lixisenatide are profoundly different from those of the longer-acting GLP1 receptor agonist. You can see in the slide that when you give lixisenatide once a day, the time that the drug is in the system with the sufficient concentration is actually a little bit more than 3 hours. While giving liraglutide once a day, you have fluctuation, of course, but all of them above what could be considered the pharmacologically effective concentration. As to the other drugs, in all the 3 trials, EXCEL, LEADER, SUSTAIN 6, we did see a decrease in hemoglobin A1c, which was massive in the SUSTAIN 6 trial, although people were shooting for equipoise. A decrease in body weight, even in this case large in the SUSTAIN 6 trial, and a decrease in systolic blood pressure. How much does this count in terms of benefit, cardiovascular benefit? Well, first of all, we have to notice that although, especially for EXCEL and LEADER, the metabolic amelioration was similar, we did have different result in the 2 trials. And in the LEADER, with the liraglutide, you did have success in preventing cardiovascular events. But also, if you analyze the LEADER trial, this result, you see that for the same amount of reduction in hemoglobin A1c in the 2 arms, you do have better results with liraglutide. And also, if you look at people with severe hypoglycemia, you still have an advantage. The same thing is when you look at subjects who did not use insulin during the trial or did not use intensification of other drugs. So in conclusion, the bulk of the evidence strongly supports the notion that treatment with GLP1 receptor agonist has beneficial effect on cardiovascular system in type 2 diabetes. And the efficacy and safety of this treatment are likely to play a role in such beneficial effects. However, the analysis from large safety CVOTs conducted with different molecules does suggest that direct effects on the cardiovascular system might also play a role, and these effects may pertain more to certain molecules, especially liraglutide. And I just want to leave you with the notion that you probably know already, that the results of this trial have been already taken up by the major agency, by the major scientific society. And if you look at the standards of care released in February by the ADASD conjunction, and you look at the new treatment algorithm, once we intensify after metformin, we have to ask ourselves, has the patient had a cardiovascular accident? If the patient did have a cardiovascular accident, then the guidelines calls for the use of at least one of the two drugs with proven effects in this patient in reducing cardiovascular events. And these two drugs are empagliflozin and liraglutide. With that, I thank you for attention and tadaraba.